Well, good afternoon on this Friday afternoon. I'd like to welcome everyone into this CHEST webinar on small cell, the forgotten lung cancer. And today we're going to be speaking about extensive stage small cell lung cancer. We did do a webinar this week on limited stage disease, but today we're going to do a webinar on extensive stage small cell lung cancer. Really happy to have a team with me today, including Dr. Mariam Alexander, an assistant professor and medical oncologist here at the Medical University of South Carolina in Charleston. Hello, Mariam.
Hi, Gerard. It's great to be here. Thank you.
Also from the Medical University, Dr. Adam Fox, an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine. Hi, Adam.
Hey there. Thanks for having me.
And we also have from Roswell Park Cancer Center in Buffalo, New York, Anurag Singh, who's a professor of radiation oncology. And today we're going to start off with a case, and I'd like to turn it over now to Dr. Adam Fox.
Hey, thanks so much. So this patient presented for this right lower lobe lesion seen on the screen. She's 78 years old. She's got a few medical comorbidities, including COPD. She's got a history of smoking, actually quit in the 1990s, has about a 30-pack year smoking history total, and presented with some self-limited increase in her respiratory symptoms that led to a chest x-ray and eventually a CT scan with this finding. For those of you looking at the mediastinum behind the heart, that's just a hiatal hernia. But so she was seen for this kind of mixed density nodule. And next slide. We did further risk stratify this nodule with a PET scan. And you can see there's really just barely any metabolic activity associated with this lesion. And there's no other concerning sites from a CT or PET perspective. Next slide. So this, we did follow this just because of its mixed density and size with a pretty short interval follow-up to make sure that we didn't detect any growth. And you can see on the left the presentation in a comparison to about 4 months later. And there was really just no change at all. So we scheduled a further follow-up. Next slide. And unfortunately, about 10 months after her presentation total, she presented with a acute respiratory symptoms, cough, shortness of breath, feeling unwell, and had a CT-PE scan demonstrated here. And you can see the very bulky lymphadenopathy on the scan. She was given antibiotics and steroids and didn't really get better after that first presentation, and then everything kind of kept getting worse, which led to this ER presentation. Next slide. So she was pretty quickly also scheduled to see us in the pulmonary group again, and also with a PET scan. And you can see that she has quite profound hypermetabolic activity in these lymph nodes, no focal pneumonia. And you can also see on our screen right, the patient's left, there's a small pleural effusion developing, and the patient did have some pleuritic chest pain during the most recent presentation as well. Next slide. So this, is a small cell lung cancer webinar, so I'm not bearing the lead to let you know that this will end up being such. But this really gets to a really classic common presentation. The patient did present with symptoms, which is quite common. You can see some of the most common presentations this patient had, which was shortness of breath, chest pain, and respiratory symptoms like cough. There are more or less common reasons to present things like hoarseness from involvement of the recurrent laryngeal nerve, bony pain from metastasis or hemoptysis. And a lot of the radiographic features are present here too. Whether there's really a large central tumor in this case is a little bit difficult because whether it's tumor adenopathy is unclear, and that's pretty common as well. You can see along with a central tumor that bulky mediastinal adenopathy is present in about 80% of cases. In almost all cases, it's present to have the tumor to be centrally located. And then there's also the growth pattern. This was not present or detectable in any way, just 6 to 10 months before when she was having these CT scans. And to demonstrate that, there are a couple studies of how quick small cell and non-small cell should double in volume. You can see from these last two bullets, the first study, we have an estimate of about 350 days to double your volume. And so probably an annual screening patient, you'll see a tumor appear and then grow over the course of time, which is pretty long. Between annual scans, it would be tough to present with metastatic non-small cell lung cancer. That's maybe part of the reason why screening can be so effective for early detection. But in small cell, you can see the volume doubling time is like 50 to 60 days. And so, in a year's time, this can really be rapidly progressive. Next slide. And then, of course, there's the association with smoking with it, which this patient has. Nearly all patients have a smoking history, especially in the United States. About 98% is what's estimated. There are a few caveats to this. One is that adenocarcinoma can present as a combined presentation with small cell lung cancer just at the time of diagnosis with no treatment. And then in the second bullet there, it can transform. Adenocarcinoma can transform if the patient has and is being treated with an EGFR tyrosine kinase inhibitor. And then finally, in part due to those last two bits, there is a preponderance of patients in Asian populations who don't have a smoking history who present with small cell. And it's probably a combination of those last two things in that they have a higher proportion of adenocarcinoma and a higher proportion of EGFR mutations in patients with adenocarcinoma. Next slide. A little more on the epidemiology of small cell lung cancer. This is all in the United States. You can see on the left figure that the proportion of lung cancers being diagnosed as small cell is decreasing over time, and it's approaching about 10% in recent years. Historically, it was a little bit closer to 20%. And then on the right figure, you can see there used to be a gap in terms of men and women presenting, a difference in men and women presenting with small cell, and that gap has now closed to where it's about 50% men and 50% women. And all of these changes in both of these figures are thought to be due to changing patterns of smoking. Overall, the amount of smoking and tobacco use we see in the United States is decreasing, and then the differences between men and women smoking is also decreasing. The difference between those two. Next slide. Here we have an estimate of stage of presentation in one study showing how many present with extensive or limited stage small cell lung cancer. And I found this figure really interesting because they were able to show a change based on our ability to detect small cell stage with PET scan. You can see in around 2010 that PET scan was being used to stage small cell lung cancer. And all of a sudden, we're having more extensive stage diagnosed. Estimates usually range from about 70% to 85%. It depends on what data you're looking at here, but the majority of patients are diagnosed in the extensive stage. Next slide. So finally, we should wrap up with a little talk about paraneoplastic syndromes. If you see a patient who has radiographic features concerning for lung cancer, lung nodule, lung mass, mediastinal adenopathy, and they're also presenting with a possible paraneoplastic syndrome, you can see most of the syndromes on this figure are going to have neurologic signs, so unexplained neurologic deficits in a patient with that constellation on radiograph should really clue us in to small cell lung cancer. The most common of these are going to be SIDH causing hyponatremia, and usually that kind of delirium or just decreased level of consciousness that comes along with severe hyponatremia. And then the myasthenic syndromes with muscle weakness would be the most common of those presentations.
Thank you, Adam. Thank you, Adam. And I just want to pick up on the paraneoplastic syndromes for a moment. The one that people normally consider in non-small cell lung cancer is hypercalcemia associated with malignancy, and that's usually seen with squamous cell carcinoma. But they occur a lot more frequently with small cells, especially extensive stage small cell. And they love to put this on the pulmonary boards on the patient with the Eden-Lambert myasthenic syndrome, where they have muscle weakness, fatigue, etc. The thing to think about when you're seeing these is that a single cycle of chemotherapy for extensive stage small cell can actually reverse some of these symptoms. And the symptoms associated with paraneoplastic syndromes can be so debilitating, particularly the neurologic symptoms, that treating the cancer is incredibly important and should be done very quickly. So again, hypercalcemia is seen with non-small cell lung cancer, with squamous cell in particular, and then all of the other paraneoplastic syndromes are usually seen with small cell lung cancer. And I'd ask the rest of the audience as they go through their talk, but it's at least 3 to 5 times a year we see someone coming in with a debilitating episode of paraneoplastic syndrome, and that's their presenting feature. Some of them present to the ER nearly comatose, if you will, with these things, severe hyponatremia, etc.
Yeah, excellent additions, Gerard. So finally, to go over just some of the spectrum of neuroendocrine tumors that one might encounter, the first of which would be carcinoid tumors, especially the typical. Those would be more common, a typical carcinoid tumor. These often are slow-growing, very smooth-bordered, often associated with a bronchus and sometimes even endobronchial. They often cause symptoms by growing into these and or bleeding rather than spreading. The atypical carcinoids can be much more aggressive, but are more rare. For the neuroendocrine carcinomas, of which small cell is one, is also large cell. It kind of acts a little bit more like a non-small cell, but it's also quite aggressive and on the rare side. And then finally, we have diffuse idiopathic neuroendocrine cell neoplasia, which many of us would just call DIPNIC. And this condition usually presents with respiratory symptoms, maybe an asthma-like picture, and you will find diffuse, usually small nodules associated with some mosaic attenuation or ground glass. And for small cell, the diagnosis is mostly made by the features on cytology or histology. The cells are small. There's often a high mitotic rate, and then there's some characteristic nuclear and cytoplasmic features that can help with that, and crush artifact is commonly seen. And then there's supporting immunohistochemical stains that can be done. The first ones listed here are neuroendocrine markers and TTF1, a lung marker, and then usually a stain called Ki-67 is elevated. Next slide.
I'm just going to hold you up there again and talk about this spectrum, right? So we see this spectrum between very benign appearing carcinoid tumors, which present as solitary pulmonary nodules. They can be very low level uptake on PET. They usually have a great outcome with surgery. Atypical carcinoid, a little bit tougher and a little bit worse prognostication with those patients. DIPNIC, we can follow those patients for years. Large cell neuroendocrine tumors are really sort of on that spectrum of non-small cell lung cancer, though more aggressive, and then there's small cell, which we're talking about today. All of these require some input from your pathologist. And so if you're struggling with this, you really need to sit with your pathologist and go over their ability to differentiate these tumors, particularly large cell neuroendocrine from small cell, which has different treatment options, and then typical from atypical carcinoid, which has different treatment options. So I'll move over to the next.
Yeah, and I would highlight for those very reasons, Gerard. It's like I cannot remember the last time I've diagnosed one of these conditions, maybe other than typical carcinoid, but they almost always end up on tumor board. We need that pathologic review and also the radiologic review to really start putting these things together on how exactly to treat them. So finally, to get to staging, this patient was diagnosed with small cell lung cancer, obviously, and once we have that diagnosis, we have to have staging information to figure out how to treat them. And there's kind of two staging systems. On the left, we have the TNM staging system. This just had its update in January of this year. It's now on its 9th version or edition, and this is the same staging that we know for non-small cell. They're identical. And then a long-standing other staging method has been to designate either limited or extensive stage. And this has to do a lot more with how tolerable the radiotherapy plan is for treatment of the bulk and extent of tumor. And for that, I want to turn over the next slide just briefly to Dr. Singh to help give us a perspective on how he considers stage from limited to extensive.
Well, so a little bit, the stage is in the eye of your friendly neighborhood radiation oncologist, and a little bit, the staging system for radiation oncology defined portals has changed over time. So if we look at panel B, this is the 1973 version where everything's got to be on one hemithorax. The pleural effusion that this patient had would make them extensive stage. But if you go to the 1989 system, now we're allowing some contralateral lymphadenopathy and we're allowing a pleural effusion. And if you go to the current AJCC systems, we're still not allowing the pleural effusion, but we're allowing a lot more. And some of that has to do with advancements in radiation therapy delivery. And some of it has to do with just changing of the presentation and better imaging. Here, for the AJCC, you'll see that T3 and T4 disease, so disease in one lobe, multiple foci, or multiple foci across several lobes of primary disease, are counted as extensive stage, even though your radiation oncologist may choose with you to treat them. So it should be a multidisciplinary decision.
Thank you, Anu. And now I'm going to turn it over to Dr. Mariam Alexander, our local medical oncologist, who's going to talk to us about treatment for small cell lung cancer extensive stage.
Thanks for having me, Gerard. So I just want to summarize the overall management of small cell lung cancer and very briefly about what we talked about in the limited stage webinar, where a small proportion, so if you look at your on the screen left, a small proportion of patients with limited stage small cell lung cancer can actually get surgery if there's no significant spread of their cancer. But we would certainly recommend some chemotherapy after treatment and possibly radiation as well if lymph nodes are found to be involved during the time of surgery. However, the majority of time for limited stage disease, we use a combination of chemo and RT and now have added consolidation immunotherapy per the Adriatic clinical trial. So for extensive stage small cell lung cancer, it does depend on their comorbidities. It is actually quite rare for us to not offer frontline chemotherapy for extensive stage disease, as most of their time when they present, their decline in performance status on presentation is due to the side effects of the small cell lung cancer, and we may be able to palliate and relieve those quickly after a few days of chemotherapy. So the frontline treatment is platinum-based chemotherapy plus immunotherapy, which I'll go over in a few slides. And then they do continue this immunotherapy maintenance until the disease relapses, at which point we would consider re-challenging them with the same chemotherapy, depending on how long their chemo-free interval was, or switch to a different second line of treatment. And we always want to say, please refer for clinical trials, especially after the frontline failure. Go to the next slide. So in terms of survival of small cell lung cancer, this graph kind of shows that if we find it earlier, and especially in the very, very early stages, the survival actually may not be so bad. But when we get to the later stages, unfortunately, less than 15% are alive at 5 years. But this is certainly changing with some of the newer therapies that I will talk about. Next slide.
Before we go to the next slide, and I know we're not talking about limited disease, but I do want to emphasize something we talked about during that, which is the limited disease, about 25% present with what's the equivalent of stage 3A, B, and C non-small cell lung cancer. And you can see that their survivorship is much better than we used to think. And I think most pulmonologists think that the limited stage small cell or all small cell has a very bad prognosis. But I wonder if you could just take a quick moment to comment on now the long survivors that we're seeing with limited stage disease treated with chemo, radiotherapy, and then consolidation immunotherapy out for 2 years.
Yeah, so immunotherapy has really changed the game for the limited stage disease after concurrent chemo radiation per the Adriatic clinical trial, which was just approved last December. And so we are seeing these really long-term responders. So some people living many, many, many years. I mean, we haven't reached many years after the trial. So, stay tuned for more overall survival data, but pretty much doubled the overall survival if I had to, say it more simply.
Okay, thank you.
And then, so just want to go back and say that chemotherapy has played a significant role in the survival. So this study actually looked at the benefit of no chemotherapy. So that is the bottom line of these two graphs. On the left is the limited stage and the right is the extensive stage, versus adding more and more cycles of chemotherapy. So they actually found that the optimal, the more chemotherapy, the better the survival, with the optimal number of cycles being about 4 to 6. If you go to the next slide. So small cell lung cancer is one cancer where there can be an improvement in outcomes if we urgently treat symptomatic patients when they present to the hospital, unlike non-small cell lung cancer. So in a study looking at patients in the ICU who were given chemotherapy during their admission, the most benefit, especially in the first 100 days after the ICU admission, was seen in patients who had newly diagnosed extensive stage small cell lung cancer compared to non-small cell or other cancers.
That brings up this idea about whether we should admit patients with small cell lung cancer. I think we all think these days, and this has changed over the 30 years of my career, where it used to be that lots of patients were admitted for evaluation and management of even non-small cell lung cancer. But now that's all done as an outpatient. We don't hospitalize patients for chemotherapy. They have an infusion chair. We don't hospitalize patients for the initial workup of lung cancer. Even when I get called from the emergency room, go down to see a patient, it's usually way more efficient for me to say, hey, come back on Tuesday to the clinic. In the meantime, we'll get an outpatient PET scan or PET CT and schedule bronchoscopy. It's kind of not the same with small cell. There's an urgency. And I wonder, Dr. Alexander, if you could just speak a little bit to that urgency about when you might say, hey, you know what, Gerard, I think we should admit this patient and get the chemotherapy in, which is what this trial sort of showed.
Yeah, I completely agree. This even limited or extensive stage small cell lung cancer is one of those. We always get a call on Friday afternoon, so I'm expecting a call sometime today, where you get that urgent call from your pulmonologist, and say, hey, the rows, when they were doing their bronch found small cell, what should they do? This is often something that I don't want to wait till Monday. I often admit these patients to the hospital to get their first cycle of chemotherapy. And it's a practical reason is because it's hard to get a chemo chair, on Monday morning. So to urgently, get chemo into the patient to shrink their cancer and to reduce their morbidity, relieve that dyspnea or that pain or, whatever presenting symptom, or even the paraneoplastic, the severe hyponatremia, that one cycle of chemotherapy quickly can make a big difference. So very important pulmonologist having a med-onc, on your favorite med-onc that you can call to discuss these cases.
We have you on speed dial, Dr. Alexander.
I'll put my cell phone in the chat. So I want to go into these pivotal Caspian and Empower 133 trials that were practice changing with the addition of immunotherapy in the frontline setting. There were decades and decades of we were just doing chemotherapy, and then 2019 things changed. So if you go back, so in the Caspian trial, patients who were treatment naive and had asymptomatic or treated stable brain mets were randomized to the standard of care at that time, which was just chemotherapy. So EP is platinum etoposide, or etoposide platinum, versus the chemotherapy with immunotherapy. So in this Caspian study, they used the anti-PD-L1 antibody called durvalumab, and they enrolled fit patients, ECOG PS01, with a good life expectancy, with measurable disease, and their primary endpoint was overall survival. So we go to the next slide.
Before I go to the next slide, I do think it's worth talking about what we constantly do in clinical trials, which is only enroll the fittest, best patients of 0 and 1. But what we see in clinic is also a little bit worse than that. Is it still reasonable, even though that the trial was done in 0 and 1, is it still reasonable for us to enroll, not to enroll patients in trial, but to send our patients to you that have a performance status of 2, which is a little bit more debilitated?
Yeah, I think for in general, I think it is good to discuss all these patients with the medical oncologist, especially in academic centers where we have trials for all these settings. But often, as I said before, that presenting small cell lung cancer could be the cause of their performance status decline, right? And so if you give them that first cycle of chemotherapy, it could certainly perk up, right? So in the real world setting, it's not done exactly like the trial. We often give that first cycle of chemotherapy inpatient, and then when they see us in clinic, they suddenly feel a lot better, and we add the immunotherapy on the second cycle. So that is one way to go around it. If you're unsure whether it's worth it for these patients to get the immunotherapy, because the goal of the immunotherapy here is that long-term survival benefit. The chemotherapy is the thing that is shrinking the cancer right away. So the median overall survival here was 12.9 months for chemo with the immunotherapy versus 10.5 months. That doesn't seem very significant, but when you, in real life, but if you go out to 36 months, which is how far they went on this trial, we can see that the difference widens a lot more, to 17.6 months for the chemo with the immunotherapy versus just 5.8 months with just a chemo alone. So if we go to the next slide, I want to go over also the Empower 133 trial, which was also done at the exact same time, a very similar design, with patients in the frontline setting, treatment naive, randomized to chemotherapy with chemo plus atezolizumab, which is also a different PD-L1 inhibitor instead of placebo, and both arms received that the standard of care chemotherapy. This trial also enroll patients that were fit, ECOG PS01. And in this trial, patients who had brain mets were usually treated. So it was treated asymptomatic brain mets patients with those were eligible. So if we look at the long-term survival data for this trial, I want to really point out here this tail of the curve, where you see at 5 years, 12% of patients are alive. So the median overall survival, very similar to the other trial, 12.3 months with the chemo plus the immuno versus 10.3 months with the chemo alone. But, there is a significant tail of the curve that has plateaued over here. And so a lot of research is ongoing right now to understand who these patients are and why they benefit more from immunotherapy compared to other patients.
I would just ask the audience to maybe take a quick look at the chart there. And, we might not think that 1 year survival of 50% is a big deal, but to patients with lung cancer, that extra year of life is important. And to have that, and then to have some stability out, 3 and 5 years, really in my career, and even up until 10 years ago, 6 years ago, we never saw this. We never saw a single patient with small cell live maybe past 12 to 18 months ever. So to see this kind of data is encouraging. And to be fair, we have started to see this much more frequently in non-small cell lung cancer, where we have really targeted agents. And so even though you as pulmonologists might not be so impressed with this data. What it signals to me is that the explosion we've seen in non-small cell lung cancer with many patients living 5 years or more is probably going to happen in small cell lung cancer as we uncouple the pathways that we might be able to interrupt. So honestly, this is really, really good news for our patients with lung cancer.
I agree. Yeah. So based on these data, the addition of immunotherapy as part of the induction treatment and as maintenance is a category 1 recommendation, with either the durvalumab or atezolizumab being reasonable options. I just want to point out here that unlike in non-small cell lung cancer, where we have certain markers such as PD-L1 expression to guide us in who is more likely to benefit, we don't have these specific biomarkers in small cell lung cancer. And PD-L1 has not so far predicted who is going to respond and who is not. So the current recommendation is to add the immunotherapy right away for all patients with extensive stage small cell lung cancer in the frontline setting. So some research points here. So identifying effective biomarkers for small cell lung cancer has been very challenging. It has a high mutation rate, so it doesn't lend itself easily to mutation-driven biomarkers. So research is actually focused on expression-based biomarkers, such as transcriptome and proteomic profiles, which is what is sort of like highlighted there on that right side. And this makes it quite tough to implement in the clinic. So in terms of expression profiles, there are 4 categories on that left, that pie chart you see there, that include major neuroendocrine subtypes and immune gene signatures that actually makes it feel like we're dealing with 4 different types of cancers. So just to, put some words out there that you may hear about in like the coming years, the subtypes are ASCL1, NeuroD1, POW2F3, and YAP1 or inflamed subtype. But these subtypes have not been validated in prospective clinical trials yet. And so I just want to point out as well, again, that when traditional biomarkers of immunotherapy, such as PD-L1 expression, were looked at in the CASPIAN and Empower 133 trials, it did not correlate with that survival benefit. So important to add immunotherapy for everybody. So these subtype-based transcription factors, these subtypes based on these transcription factors may actually become more important in the future to predict who is going to respond to therapy. There are some studies going on to look at other biomarkers such as SLOFN11 and high MYC expression, for which like the certain small molecules can be useful. But this is all in clinical trials. So just lots and lots of research going on. So just stay tuned for all these studies. You can go to the next slide. This is this drug, the Tarlatamab, tells us we're in a really, really exciting time for small cell lung cancer. This drug, Tarlatamab, was approved in May of 2024. And what it is a bispecific T-cell engager, which essentially, like, it's a 2-arm molecule, and it forces the immune system to be in very close proximity to the small cell lung cancer. So one arm is against DLL3, which is usually expressed on small cell lung cancer cells and not really expressed anywhere else. And then the other arm is on the T cell. And that leads to T cell activation and killing of the tumor cells. So if you go to the next slide, in the Delphi 301 study, they found the different colors here, just showing the different doses that they were looking at in the trial. There was a response rate of up to 40%, which is quite a lot for patients who have already progressed on multiple lines of therapy. So on average here, they at least progressed on 2 lines of therapy. And so this swimmer's plot is just showing that this majority of these responses actually lasted maybe more than 6 months even.
Before we go on to the next slide, Mariam, I guess the logical question for me would be, well, if this is now 3rd line and we're getting 40% response, well, are we studying this as a 1st or 2nd line agent? Because it seems like the pathway is there. It's a logical pathway. And so could you tell us whether we can expect to see this maybe in the 1st and 2nd line setting?
We can certainly expect to see this in the first or second line. We actually have the first line trial open right now at MUSC, and it's been going great. So where it's being added is in that maintenance. So after the frontline, you give them that 4 sessions, 4 cycles of chemo and immunotherapy, and when you're on that immunotherapy maintenance is when we've added the Tarlatamab. And it is right now also being studied in limited stage disease as part of that maintenance with immunotherapy. I think that the extensive stage will result within the next year. So important to stay tuned to ASCO highlights because it'll be reported there. This slide is showing that the overall survival. So, it's nice to have all this response rate, but, you really want to see the overall survival, which is a gold standard. So that graph on the top left there is just 2 different doses, the blue and the red line. And it's basically showing that the median overall survival was more than 14 months. And remember, these patients have already progressed on at least 2 regimens, including immunotherapy. So that's really unprecedented for small cell lung cancer after failure of frontline treatments. I haven't shown this here, but it is even effective in the brain, with more than 30% actually experiencing shrinkage of their brain mets with this drug. And because they did enroll patients with stable brain mets, they found that more than 87% of patients actually experience stable intracranial disease. The bottom right over there is kind of showing that the drug has have unique side effects that will require close monitoring, especially in the first cycle, which is that first month of treatment, such as cytokine release syndrome and neurotoxicity. This is relevant for critical care physicians to know because we often actually consult the ICU when these toxicities turn into grade 2 or 3. These usually just happen in the first or second cycle of treatment, usually in the first cycle. So cytokine release syndrome, as you may already know, is when you have these excessive cytokines, released. So if patients become very sick, needing get into hypoxic respiratory failure, very high fever, and things don't get better with suppression such as anti-IL-6 like tocilizumab or giving steroids. They do need a lot of support to get through. But this is on there's a very, very few patients actually going through this. The ICANS is a neurotoxicity syndrome, and so that also needs to be monitored. Some of these patients also need closer monitoring in an ICU setting sometimes. But, that's also even more rare than the cytokine release syndrome. In that frontline trial that I talked to you about, that we have open here and it's open widely in the U.S. And in the world, they are actually looking at one of the things that they're looking at on that trial is only outpatient monitoring. So right now we do admit for that first and second dose of the infusion, just to monitor these patients for that cytokine release. But it is coming very easily outpatient. So just stay tuned for that. But it's just exciting to see that these are not very. I'm pointing out these toxicities, but they are not very toxic drugs and very good quality of life. And so I'll go to the next slide. And so this is just to show you that there are several different antibody drug conjugates that act as smart missiles that deliver chemotherapy in a very targeted way. Several of these antibody drug conjugates target proteins such as DLL3, B7H3, SEZ6, and they're very, very promising. Some of these compounds are moving quite quickly through the phases of study. The B7H3 compound, for example, called Infitamab deruxtecan or IDXD, has a response rate of more than 54% and also some benefit in the brain. So just to summarize, traditionally we have used chemotherapy such as topotecan and lurbinectedin for these patients who progressed on frontline chemo and immuno. So it is finally nice to see some new ways to target small cell lung cancer that is showing promise. And it does appear that some of these agents will significantly and clinically meaningfully prolong life in our patients.
Well, thank you. I'm going to turn this over to Dr. Anurag Singh, our radiation oncologist, to talk about when and if to use radiation therapy in patients with extensive disease. We do know that it's part of the curative intent regimen for limited disease, but where is it found to be useful in extensive stage? Dr. Singh?
So in extensive stage, the first question is, should we consolidate with radiation if they have an excellent response to chemotherapy? And the data for that is a little bit mixed. So there was an older study from Jeremic that did show that there was an advantage to adding consolidation thoracic radiation, but a more recent study by Slotman failed to reproduce that result. Now, as Dr. Alexander pointed out, we are no longer just doing chemotherapy. We are hopefully doing chemotherapy and immunotherapy. And in that setting, the data is really non-existent. But we do have some early phase trials that are looking at radiation therapy in the setting of immune checkpoint inhibitors, but nothing that's phase 3 for us to discuss at the moment. Next slide. Another issue is, what about prophylactic cranial irradiation versus observation in extensive stage? So the one thing that I'll point out is that in the Caspian trial, PCI was in the chemotherapy-only arm, but not in the durvalumab arm. So this data also has to be taken in the context that we are no longer just doing chemotherapy alone. But even in that context, it appeared that the CNS imaging was a more important factor. The Japanese study required CNS imaging, and the European study required CNS imaging only if symptomatic. The European study showed a benefit to PCI, whereas the Japanese study actually showed a trend towards favoring observation. Next slide. And this was reflected in the percentage of patients who ended up developing brain mets. Next slide. Sorry. And in the Japanese studies, the symptoms were slightly more in the PCI arm, but in the European study, they did show greater fatigue, appetite loss, nausea, and leg weakness. Next slide. So as a result of these competing studies, we still have an open question for small cell lung cancer. And the Maverick trial looks at limited and extensive stage, no prior brain mets, or no brain mets on MRI after first-line therapy, and randomizes patients to prophylactic cranial radiation or not, followed by MRI brain surveillance. And so if the patient is eligible and willing to sign up for the study, that's what we would offer them. For those patients who are not interested in that, next slide. We discuss PCI, but we prefer to observe and treat with Gamma knife when needed. Thank you.
Before we go on at all, Dr. Singh, I'd like to get into a little bit more of this discussion around Gamma knife versus prophylactic cranial radiation. Can you just describe the difference for our audience? We often see these patients in follow-up, both for non-small cell and small cell lung cancer, and they might present to us with, a new onset headache. We get the CT scan. They might have 1 to 3 brain mets, and we refer to our colleagues in radiation therapy and, start Decadron. And then there's this issue of whether it's TCI or whole brain radiation versus Gamma knife, which has become a lot more popular. Can you tell us about the differences and how that treatment's set up and how long it takes and such?
Yeah, absolutely. And thank you for the question, Gerard, because there's a lot of confusion about these topics. So when we talk about whole brain radiation, literally that's what we're talking about. We're talking about the whole brain. So I bring the patient in, I lie them down on the treatment table, I wrap some tape around them to keep them from moving too dramatically. I turn the light field on the machine, turn it to the lateral edge, and if I wanted to, in the old days, all I would do is open up a square box of radiation, come at the angle of the eyelid okay, and follow back down past the ear, and basically I'd be guaranteeing that I covered the whole brain in that situation, and I could really treat just based on, without a CT scan or anything, just based on the separation of the cranium for my lateral field. So that's a very easy treatment, can be done with just a pencil and paper and a light field on the weekend. Gamma knife is one of many ways of delivering stereotactic radiosurgery. So let's talk about that in general. So gamma knife is a particular machine. Stereotactic surgery is the process. And in that process, what we do is we have the patient, we put a frame around them, okay? And that's the stereotactic part, because we're creating an external coordinate system. And then we have the patient get an MRI at the time of treatment, as well as a high quality CAT scan. We merge those images together, find exactly where the tumor is on those images relative to that stereotactic frame, and then figure out exactly how to deliver the radiation dose in a very focal manner just to the areas of disease, with a very rapid fall off of the dose. So in that circumstance, you're getting very little dose to normal brain and very high doses to the brain tumor itself. And so in that way, it's sort of the ultimate brain sparing approach. And that treatment can really be done in a single treatment most of the time, whereas whole brain radiation requires 10 treatments.
And just from a historical perspective, because I think pulmonologists are used to SBRT or radiosurgery in the lung, didn't it all start with the brain? And then you guys,
Absolutely.
hey, let's take it to the lung. Maybe these guys in the lung could use our help.
Yeah, no, absolutely. So, one of the first ways was a gamma knife based system of treating brain metastases in that manner. And then as the technology has improved, we've been able to expand that to the body as well.
I'm going to just go off topic for 1 second, because you taught me this, and it's one of the reasons I've enjoyed having conversations with you. But when Timmerman first had that New England Journal of Medicine article about SBRT in the lung, they did 3 to 5 treatments over a 2 to 3 week period. But one of the things you've taught me, particularly in your rural population, is that we might be able to do single fraction SBRT to the lung now and get a similar result. I just this is not on topic, but it's so important for our pulmonologists to understand that they have options for these small lesions in the lung that all started in the history of the brain for small cell lung cancer, if you will.
Yeah, no, absolutely. And so our brain colleagues historically would treat with only a single treatment and get excellent results. When Dr. Timmerman was doing it in the lung, he had concerns about, what was going to be the tolerance of the heart to these types of things. Those were all unknown issues at the time. And so he sort of arbitrarily decided that, he was going to be conservative and do 3 treatments. And that's what he did. It turns out that SBRT is stereotactic body radiation therapy, is actually a CMS-defined billing code, which will pay you for up to 5 treatments. And so people thought that the conservative way, or the safer way of doing things, was to give people 5 treatments. As you know, some of us have difficulty bringing patients in even for a single treatment, much less 5 treatments over the span of 2 weeks. And so groups have developed the clinical trials to do single fraction body radiation, and have found great success, not just in lung but in kidney as well. Okay, we've done spinal cord radiation, and so it appears that single fraction is feasible in a variety of tumor types and locations, lung, liver, kidney, spine. And as a result, our patients have that many more options. Plus, as Dr. Alexander has pointed out, particularly in a disease like extensive stage small cell lung cancer, these patients have a lot of effective therapies, but those therapies can be given over a very, very long time. And one of the things we need to do is, if we're going to think about intercalating additional therapies, it's got to be done and out of the way, right? Because it can't interfere with the long duration immunotherapy, can't interfere with the chemotherapy, or some of those exciting compounds that Dr. Alexander was mentioning at the end. And you certainly don't want to do studies about combined toxicity. So what you want to do is, if you're going to find and do a local therapy, you want to do it and get out of the way as quickly as possible.
Thank you for that sidebar. I think it was well worth it for our audience. So let's go back to Adam finishing up here.
So this is both of these images are from the same scan 2 years after her initial presentation. She was treated with chemotherapy and immunotherapy, and you can see on the left lung window image here, this kind of part solid lesion is pretty much unchanged. Some of those areas, it's just tough to show on a single image, are really blood vessels, but there is still this kind of solid portion to it, and almost no change over 2 years. And then on the right-hand image on the mediastinal windows, you can see that all of the bulky mediastinal adenopathy is greatly diminished. You can see a few lymph nodes there, but none of them are pathologically involved or enlarged. And so a really nice response over 2 years for this patient who is treated as extensive stage due to that pleural effusion. Next slide. And this patient did not undergo any prophylactic cranial radiation and was followed with frequent MRIs. And just on her last MRI, unfortunately, a highly suspicious lesion for metastasis was found, but treated with stereotactic radiosurgery in a single fraction. So she'll continue under surveillance, but so far it took 2 years to get this one spot. But otherwise, clinically is well and active.
So I'm just going to have some take-home points, and then we'd love to answer some questions from the audience. So over decades, we've seen lower rates of small cell lung cancer in the United States due to a decline in smoking. What's clear to me, though, is we've been very nihilistic about lung cancer writ large, but particularly about small cell lung cancer. As pulmonologists, I would urge my colleagues to make sure that every patient has the opportunity to see a medical oncologist for at least discussions of treatment. Listen, it's up to the patient, and if the patients choose not to be treated, I completely understand. However, I encourage my patients to see an oncologist for a couple of reasons. One being that I think their quality of life can improve so greatly, even with a single cycle of chemotherapy, where their pain is relieved, their dyspnea is relieved, their cough is relieved. But now that we have these other treatments with immunotherapy and other targeted therapies coming down the line, I think we have this opportunity to really get some long-term survivors and also build on this with clinical trials, which of course all of us encourage our patients to enroll in clinical trials. And in the United States, for lung cancer, less than 5% of patients ever end up on a clinical trial, which is not nearly as much as end up on trials for breast cancer and other cancers. So really need to improve there. We think multidisciplinary, and I hope I showed you that this group of 4 people on this line, plus adding in a pathologist and a radiologist and such, that team approach is really essential for taking care of all cancer, but particularly small cell cancer, because of the urgency of getting those patients treated. I hope you've learned a little bit about the difference between limited disease and extensive disease, about whether you should do PCI or surveillance MRI, and I think all of us are leaning more towards surveillance MRI, as was seen in our patient when they can get treated with a single fraction of radiosurgery to the brain should they develop METs. Immunotherapy is the first true advancement, at least in the last 20 years in small cell lung cancer. And I think, as Dr. Alexander showed, with more clinical trials and more things on the docket, I think over the next 5 years, we're going to see huge advances in the treatment of small cell, which lagged a little bit behind non-small cell, but are starting to catch up. And so with that, I'm going to open it up to see in our chat. I hope to see in our chat that we have, if we have any questions. So let me open it up and see if there are questions in our chat box. And right now I don't see any. It is Friday afternoon and a lot of people want to get to happy hour, but we'd be happy to answer a few questions. While we're waiting for any questions to come through, I would urge people when they become available to go back and look at the limited stage small cell webinar. That'll be an enduring product with CHEST. And also the same group did several podcasts, short podcasts, which were actually a lot of fun. And those are short, 15 to 20 minutes long. And there's a question from JD. Can you comment on the role of serum markers such as Notify at the time of the nodule was discovered? So I think I'll take that since I've done some research in with that in particular product. The Notify, which is looking at whether you can lower the risk or raise the risk that a pulmonary nodule in the intermediate risk profile, it can be lowered or raised by using the XL2. And what I would say there is not for small cell. It is very useful for non-small cell pulmonary nodules, but for small cell, I think it's probably, first of all, we don't see very many small nodules in small cell lung cancer, right? So that's usually a couple of times a year where we get surprised. The patient goes to surgery, and afterwards the pathologist calls us up and says, "Oh my gosh, that was a small cell that presented with a 2 centimeter or less pulmonary nodule." In those instances, they go directly to our tumor board conversation, and usually, as Dr. Alexander pointed out, they get treated with chemotherapy, and if they had mediastinal adenopathy, get treated with radiotherapy as well. AP, thanks for an excellent session. You're welcome. Can we explore the management of CRS in preparation for when Tarlatamab becomes used frequently? Mariam, you want to take that?
Yeah. So Tarlatamab is already being used frequently. So that's great news. And so right now, centers that are used to administering bispecific T cell engagers, which are a lot more common for multiple myeloma, are much more used to monitoring the cytokine release syndrome and the ICANS. In terms of cytokine release syndrome, if patients can notify us early on, and it's mainly their caregivers that are notifying us that they're not feeling well or they have a fever, that kind of stuff, if they're short of breath, we can intervene a little bit faster by giving them maybe some pills like dexamethasone, so that they can try to prevent having to come to the hospital. But we often tell them to come to the hospital. We give them a little card, that tells what is a drug that they're on, so that the ER physician who may not be as familiar can look it up, or at least even try to page the oncologist at the center that's administering it. But if tocilizumab, which is the anti-IL-6, is quite key in trying to manage this, but that is usually administered not in a community ER, but in a more bigger center.
Yeah, so I think it's really early acknowledgement that it exists. And I think pulmonologists have gotten used to some of the regular immunotherapy-induced side effects like pneumonitis. I think we need education as these become more available. I think in academic medical centers with high-end ICUs, I think it's more common for us to manage this, but we should start educating both families, patients, and physicians. Beth, great session. Thank you. Looking forward to seeing Gerard at the roundtable. Okay. I'm looking forward to seeing you guys too. Thank you. I guess with that, I don't see any other questions.
Gerard, I do see another question in this other question and answer box from Joel Claren. It says, will there be a role for CAR T cells against DLL3 while treating small cell lung cancer? So, Yeah, actually, there is a CAR T already. We didn't have that trial at our center, so I didn't have experience administering it myself, but it has been administered in other centers. Some response, it's kind of very, very early days for that because solid tumor folks we are not as used to using CAR T as the leukemia folks, the malignant hematologists. So very, very early days, but there is a CAR T designed, and it's in clinical trials.
Okay, with that, we're coming to the end of the program today. I really want to thank Adam Fox, Assistant Professor of Pulmonary at MUSC, and Dr. Singh from the Roswell Park Cancer Center, radiation oncologist and professor, and Mariam Alexander, Assistant Professor at MUSC as well. I'm Gerard Silvestri, and I really want to thank everyone for tuning into this webinar on small cell, the forgotten lung cancer. Thank you very much, and we'll be seeing you down the road.
Thank you.